Welcome to your practice question review for the ATI Fundamentals exam. Every question mirrors the real exam. We break down why the right answer works, why the others fail, and the concept that ties it all together. Today's management of care questions cover levels of care and healthcare financing, quality and safety competencies, the interdisciplinary team, negligence, consent and advanced directives, documentation and reporting. Our website offers free exam guides and practice questions to help you succeed on your ATI Fundamentals exam. You'll find everything you need to prepare effectively and build your confidence. Just check the link in the description below to get started, and remember to study smarter, not harder, as you prepare for your exam. Alright, let's jump right in. Question 1. The nurse is describing levels of healthcare to a group of new staff. Which setting should the nurse identify as an example of tertiary care? Your options are A. A community prenatal clinic, B. A skilled nursing facility, C. A burn treatment center, D. A school immunization program. Which one is it? Pause the video if you need more time. The correct answer is C. A burn treatment center. C is correct because tertiary care provides specialized, highly technical services for serious conditions, and a burn treatment center fits that level. Its advanced equipment and expertise place it above the general care delivered in other settings. A is wrong because a prenatal clinic delivers primary care through a sustained partnership focused on health promotion. It supports wellness rather than the complex specialized treatment that defines the tertiary level. B is wrong because a skilled nursing facility offers restorative care, helping clients recover function after acute treatment. That follow-up role sits below the highly specialized services a tertiary center provides. D is wrong because an immunization program represents preventive care because it educates people and reduces risk before disease develops. Preventive services aim to keep people well, not to treat serious established conditions. Healthcare is organized along a continuum, from routine everyday contact all the way to narrow, high technology treatment for the most serious conditions. Primary care is the sustained first contact relationship focused on prevention. Secondary care treats acute problems in a general hospital. Tertiary care is the specialized tier above that, reserved for subspecialists and dedicated technology. Restorative care follows the acute episode to help someone return to baseline. Picture a burn treatment center, specialized wound teams, isolation rooms, and grafting technology, all built around one narrow, complex problem. That concentration of advanced resources is what separates tertiary care from a general hospital floor that simply treats sick people broadly. A prenatal clinic monitoring healthy pregnancies is primary care. A skilled nursing facility rebuilding function is restorative care. A school immunization program is prevention, not a treatment level at all. Only the burn center, with its concentrated specialized expertise, qualifies as tertiary care. Remember, levels of care describe how specialized a setting is, while levels of prevention describe when an intervention acts against disease. Keeping these two frameworks separate is the key to avoiding the most common mistake on this topic. Question 2. A client asks the nurse which health programs receive federal funding. Which of the following programs should the nurse identify as federally funded? Your options are A. Medicare, B. A preferred provider organization, C. A long-term care insurance plan, D. Traditional fee-for-service insurance. Take a second. Which answer would you pick? The correct answer is A. Medicare. A is correct because Medicare is a federally funded program that covers hospital and provider services for older adults and people with long-term disabilities. Its federal financing distinguishes it from the private plans the client mentioned. B is wrong because a preferred provider organization is a private plan that lets clients choose from contracted providers. Private dollars, not federal funding, support it, so it does not match the description. C is wrong because long-term care insurance is purchased privately to cover expenses that federal programs do not. Because individuals fund it themselves, it falls outside the category of federally funded coverage. D is wrong because traditional fee-for-service insurance reimburses providers privately for each service rendered. It operates through private payment rather than federal financing, which places it outside the programs the client asked about. How does America actually pay for health care? It comes down to two very different money sources: public financing from government taxes and private financing from premiums people and employers pay to insurance companies. The federal government stepped in because certain groups couldn't reliably buy coverage on their own. Before Medicare existed in 1965, about half of older Americans had no hospital insurance at all, since private insurers saw them as too costly. Medicare fixed this by pooling risk across the whole working population through payroll taxes. Medicare itself is built in parts. Part A covers hospital stays, funded by payroll taxes from your working years. Part B covers provider visits for a monthly premium. Part C bundles benefits through private plans. And Part D adds prescription coverage, but all of it runs on federal dollars and national rules. Here's the trap. A plan can look official and still be private. A preferred provider organization, a fee-for-service policy, and long-term care insurance all move private premium dollars from policyholder to insurer. Only Medicare draws its money from the federal treasury and payroll taxes. Medicare and Medicaid get confused because both are public, but Medicare is purely federal and tied to age or disability, while Medicaid is shared federal-state funding tied to income. Private plans are a third category entirely, funded by premiums, always sought by the money source, not the name. Question 3. A nurse reviews current research and uses the findings to update a wound care procedure on the unit. Which quality and safety competency is the nurse demonstrating? Your options are A. Informatics, B. Teamwork and collaboration, C. Patient-centered care, D. Evidence-based practice. Before I reveal it, which one do you think is right? The correct answer is D. Evidence-based practice. D is correct because evidence-based practice means basing care on current research and credible knowledge. By using study findings to revise the procedure, the nurse applies the best available evidence to improve client care directly. A is wrong because informatics is the use of information technology to gather data and support decisions. The nurse drew on research findings, not a technology system, so this competency does not match the action. B is wrong because teamwork and collaboration describes partnering with other team members to coordinate care. Updating a procedure from research is an individual evidence task and does not center on working with a team. C is wrong because patient-centered care focuses on honoring a client's preferences, values, and participation in decisions. The action here involved applying research to a procedure, which reflects a different competency entirely. Evidence-based practice means using the best current research, blended with clinical expertise and patient values, to guide care decisions. It's a core quality and safety competency, ensuring actions are justified by sound knowledge rather than habit or tradition. These three are often confused because all involve data and better care. Research creates brand new knowledge. Evidence-based practice applies existing outside knowledge to a decision. Quality improvement measures and adjusts a unit's own local process over time. The method follows a clear arc: frame a clinical question, search the literature for the strongest studies, appraise the evidence for quality, then integrate it with clinical judgment and patient preferences before changing practice. Watch for phrases like current research, study findings, or published guidelines. These flag evidence-based practice. Language about tracking a local process points to quality improvement, and language about a technology system points to informatics instead. A nurse who reads outside studies on dressings and updates wound care is practicing evidence-based care. Recognizing that the knowledge came from beyond the unit is what settles the category every time. Question 4. A unit team tracks call light response times and develops a plan to reduce delays. Which quality and safety competency does this effort represent? Your options are A. Safety, B. Quality improvement, C. Informatics, D. Evidence-based practice. What's your answer? Commit to one before I continue. The correct answer is B. Quality improvement. B is correct because quality improvement uses care and organizational processes to develop and carry out plans that better meet client needs. Tracking response times and acting to reduce delays is a clear quality improvement effort. A is wrong because safety focuses on minimizing risk factors that could injure clients or staff. While related, this effort centers on measuring and improving a process over time, which defines quality improvement instead. C is wrong because informatics involves using information technology to communicate and guide decisions. The team did gather data, but the defining feature here is a structured plan to improve a process, not the technology. D is wrong because evidence-based practice draws on published research to guide care. This team analyzed its own unit data and built an improvement plan, which reflects quality improvement rather than applying outside evidence. Quality improvement is the ongoing effort to study a local care process, find where it falls short, and change it to better meet patient needs. Unlike evidence-based practice, it looks inward at a unit's own data rather than outside research. The idea grew out of manufacturing, where studying a process with data made it more reliable. Instead of blaming the individual worker applied to healthcare, it shifts the question from who made a mistake to why the process allowed one to happen. The work follows a repeating cycle: plan a change, do it on a small scale, study the results, and act on what the data show. A team picks a measurable indicator, like call light response times, collects a baseline, tests an intervention, and remeasures to see if it improved. Picture a unit team that notices complaints about slow call light responses. They log times for 2 weeks, find an average of nearly 9 minutes, assign a staff member to monitor the lights, and remeasure to confirm the delay shrank. Evidence-based practice imports knowledge from outside research. Quality improvement generates its own internal measurements to refine a local process. When a team studies its own workflow and iterates on its own numbers, that's quality improvement. Question 5. A client wants to include a personal prayer ritual in the daily routine while hospitalized, and the nurse adjusts the schedule to allow it. Which competency is the nurse showing? Your options are A. Quality improvement, B. Informatics, C. Patient-centered care, D. Delegation. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is C. Patient-centered care. C is correct because patient-centered care provides compassionate, culturally sensitive care that honors a client's values and preferences and includes them in decisions. Adjusting the routine for the client's ritual reflects this competency directly. A is wrong because quality improvement involves changing organizational processes to better meet needs across many clients. Honoring one client's personal preference is an individual caring action, not a process improvement initiative for the unit. B is wrong because informatics is the use of technology to gather information and support clinical decisions. Nothing in this situation involves a technology tool, so this competency does not describe the nurse's action. D is wrong because delegation is the transfer of a task to another team member while keeping accountability. The nurse personally adjusted the schedule, so the situation reflects client-centered values, not a delegation decision. Patient-centered care means treating the client as a partner in their own treatment, honoring their values, preferences, and expressed needs rather than simply issuing orders they must follow. This idea corrects a long era of paternalism, when schedules and plans were built around institutional convenience. Research showed that ignoring what patients valued led to worse adherence, worse satisfaction, and sometimes worse outcomes. So centering care on the person became both an ethical and practical priority. Picture a patient who prays at a set time each day and asks the schedule to leave room for it. A nurse who shifts a dressing change or medication time so the ritual goes undisturbed is practicing patient-centered care. The key distinction is scope. Patient-centered care honors one specific person's values in the moment. Quality improvement changes a process for many clients at once, and informatics involves a technology tool, or a squeetiwig swat is saib, neither of which applies here. Whenever a scenario turns on honoring what an individual client wants, the concept at work is patient-centered care, not a system-level competency. Question 6. A client who has terminal cancer wishes to go home, but needs medical equipment and community services arranged. Which team member should the nurse consult? Your options are A. Social worker, B. Physical therapist, C. Respiratory therapist, D. Radiologic technologist. Which would you go with? Lock it in before the reveal. The correct answer is A. Social worker. A is correct because a social worker coordinates community resources and equipment to meet psychosocial and environmental needs for discharge. Arranging home services for this client fits squarely within the social worker's role. B is wrong because a physical therapist works to improve mobility and strength, especially in the lower extremities. That expertise does not address arranging home equipment and community services, which this client actually needs. C is wrong because a respiratory therapist manages oxygen, nebulizer treatments, and other breathing therapies. The client's request concerns discharge logistics rather than respiratory support, so this referral would not solve the problem. D is wrong because a radiologic technologist positions clients and performs imaging studies for diagnosis. Nothing about ordering home equipment or community services relates to imaging, making this team member the wrong choice. Medical treatment alone rarely gets a client safely home. Let's look at why hospitals rely on social workers to close that gap. A client can be medically cleared for discharge yet stuck because there's no bed at home, no way to pay for oxygen, or no one to help with meals. Unmet social and financial needs stall recoveries and drive readmissions just as surely as unresolved medical problems. The social worker assesses a client's home situation, finances, and support network, then links them to the right services, durable medical equipment, home health or hospice, financial assistance, transportation, and facility placement. The key distinction is resource coordination versus hands-on clinical therapy. A social worker arranges the scaffolding around a client, while physical therapists, occupational therapists, respiratory therapists, and dietitians all treat the body directly. When a client is medically handled but needs equipment, placement, or financial help arranged before going home, that's a social worker consult, not a therapy referral. Question 7. After a stroke, a client struggles to use eating utensils with the dominant hand. Which member of the interprofessional team should the nurse consult? Your options are A. Speech-language pathologist, B. Registered dietitian, C. Social worker, D. Occupational therapist. Don't overthink it. Which one feels right? The correct answer is D, occupational therapist. D is correct because an occupational therapist helps clients regain skills for activities of daily living, especially upper extremity tasks like self-feeding. Relearning to handle utensils after a stroke falls within this therapist's scope. A is wrong because a speech-language pathologist evaluates speech, language, and swallowing problems. The client's difficulty is motor control of the hand, not swallowing, so this specialist does not match the need. B is wrong because a registered dietitian plans nutrition and therapeutic diets. The issue is physically managing the utensil rather than what the client eats, which places this concern outside the dietitian's focus. C is wrong because a social worker arranges community resources and discharge support. Helping a client relearn a hand skill is a rehabilitation task, not a resource coordination matter the social worker would handle. Occupational therapy is not about jobs. The occupation in the name refers to the everyday tasks that occupy a person's day, like eating, dressing, grooming, and bathing. The discipline exists because medical recovery and functional independence are two different things. A person can survive an illness or injury and still lose the hand and arm skills needed to live on their own, and that's the gap occupational therapy fills. Consider a stroke patient who can no longer manage a fork with their dominant hand. The issue isn't leg weakness or swallowing, it's the fine motor control needed to grip and guide the utensil. So an occupational therapist retrains the hand or provides an adaptive utensil. The key distinction examiners test is the split between occupational and physical therapy. Occupational therapy owns the upper extremities and activities of daily living, while physical therapy owns the lower extremities, gait, and mobility. A client relearning to walk needs a physical therapist, while a client relearning to feed or dress themselves needs an occupational therapist. Whenever you see utensils, buttons, or grooming, think occupational therapy. Question 8. A client who has chronic lung disease becomes short of breath and asks for a breathing treatment. Which team member should the nurse consult? Your options are A. Occupational therapist, B. Physical therapist, C. Respiratory therapist, D. Registered dietitian. Got a guess? Lock it in. The correct answer is C. Respiratory therapist. C is correct because a respiratory therapist evaluates breathing status and delivers oxygen, nebulizer treatments, and chest physiotherapy. A client who is shorter of breath and needs a breathing treatment falls within this therapist's expertise. A is wrong because an occupational therapist focuses on daily living skills and upper extremity function. Shortness of breath calls for respiratory expertise, which is not part of what this therapist provides to clients. B is wrong because a physical therapist builds mobility and strength, especially for walking and transfers. A breathing treatment requires respiratory knowledge rather than the musculoskeletal focus this therapist brings to care. D is wrong because a registered dietitian addresses nutrition and special diets. A request for help with breathing has nothing to do with meal planning, so this referral would not meet the client's respiratory need. Respiratory therapy exists because breathing care became too technical for general staff. Ventilators, blood gas readings, and precise oxygen delivery demand a dedicated expert, especially when small errors carry large consequences. A respiratory therapist assesses lung sounds, oxygen saturation, and blood gases, then delivers the matching intervention, oxygen, nebulizer or inhaler treatments, chest physiotherapy, or ventilator management, adjusting as the client's breathing changes. The deciding feature is always the airway and gas exchange. If the client's central problem is moving air, clearing the lungs, or maintaining oxygenation, respiratory therapy is the match. This separates respiratory therapy from physical therapy, which builds strength and mobility, from occupational therapy, which handles daily living skills, and from a dietitian who manages nutrition. None of them deliver a breathing treatment. Short of breath, breathing treatment, oxygen, nebulizer, inhaler, chest physiotherapy, and ventilator all point to one consult. The symptom names the system, and the system names the therapist. Question 9. A client has a low albumin level and unexplained weight loss, and the nurse plans a referral. Which team member is most appropriate to consult? Your options are occupational therapist, B. Registered dietitian, C. Speech-language pathologist, D. Physical therapist. Which one is it? Pause the video if you need more time. The correct answer is B. Registered dietitian. B is correct because a registered dietitian assesses nutritional status and designs special diets. A low albumin level paired with weight loss points to a nutrition problem, which makes the dietitian the right consult. A is wrong because an occupational therapist helps clients regain daily living skills like dressing and self-feeding. A nutritional deficit is not a motor skill problem, so this therapist would not address the underlying cause. C is wrong because a speech-language pathologist treats swallowing and communication disorders. Unless the client cannot swallow, low albumin and weight loss reflect nutrition rather than a swallowing impairment the specialist manages. D is wrong because a physical therapist improves strength and mobility. While nutrition affects energy, the lab finding and weight change call for dietary assessment, not the exercise-focused care a physical therapist delivers. A registered dietitian assesses nutritional status and designs therapeutic diets that treat or support a medical condition. They translate lab values, weight trends, and diagnoses into a concrete eating plan whenever the problem is what and how a client is nourished. Nutrition is medicine that's easy to overlook. Malnutrition slows wound healing, weakens immunity, and lengthens hospital stays, so hospitals rely on dietitians to catch these deficits before they worsen a patient's recovery. The dietitian evaluates intake, weight history, and markers like albumin and prealbumin, then builds a plan to close the gap, restricting sodium for heart failure, controlling carbohydrates for diabetes, raising protein and calories for a wound, or designing tube feeding formulas. Low albumin paired with unexplained weight loss signals a nutritional deficit, the dietitian's territory. That differs from a swallowing disorder, which belongs to speech-language pathology, and from difficulty handling utensils, which belongs to occupational therapy. Watch for albumin, prealbumin, weight loss, and malnutrition. Those phrases flag the dietitian. When the clue is a lab value or a weight trend rather than a swallow or a hand, the dietitian is the correct consult. Question 10. A client is recovering from hip replacement surgery and needs to relearn safe walking and rebuild strength. Which team member should the nurse consult? Your options are A. Physical therapist, B. Occupational therapist, C. Respiratory therapist, D. Spiritual support staff. Take a second. Which answer would you pick? The correct answer is A. Physical therapist. A is correct because a physical therapist assesses and plans care to improve musculoskeletal function and lower extremity mobility. Relearning to walk and regain strength after hip surgery is a core physical therapy goal. B is wrong because an occupational therapist concentrates on daily living skills and upper extremity function. Gait training and lower body strengthening fall outside that focus, so this therapist would not lead the client's recovery. C is wrong because a respiratory therapist manages oxygen and breathing treatments. Walking and strength after surgery involve mobility rather than respiratory care, which makes this referral a poor fit for the client's goal. D is wrong because spiritual support staff provide comfort and address spiritual needs. Helping a client walk again is a rehabilitation task, not a spiritual concern, so this referral would not meet the physical goal. Physical therapy is the discipline that restores movement. It focuses on mobility, gait, strength, balance, and the lower extremities, rebuilding the ability to stand, walk, transfer, and climb stairs after injury, surgery, or illness. After surgery or bed rest, muscles weaken, joints stiffen, and balance falters, putting a person at risk for falls, blood clots, and lost independence. Physical therapy exists to rebuild mobility deliberately and safely, rather than leaving recovery to chance. A physical therapist assesses strength, range of motion, balance, and gait, then builds a program around progressive strengthening, gait training, balance work, and safe transfer techniques, always centered on the lower body function that supports standing and walking. The key distinction: physical therapy owns walking, transfers, strength, and the lower extremities, while occupational therapy owns dressing, feeding, and the upper extremities. A client relearning to walk after hip surgery needs the mobility specialist, not the self-care specialist. Watch for the language: walking, gait, ambulation, transfers, strength, and mobility point to physical therapy. A client whose goal is to move safely, again, always belongs with the physical therapist. Question 11. A client who has severe heart disease decides to refuse a recommended surgery, and the nurse supports the client's right to choose. Which ethical principle is the nurse upholding? Your options are A. Justice, B. Fidelity, C. Beneficence, D. Autonomy. Before I reveal it, which one do you think is right? The correct answer is D. Autonomy. D is correct because autonomy is the client's right to make personal decisions, even ones that may not appear to serve their best interest. Honoring the refusal of surgery respects that right directly. This is wrong because justice concerns fairness in how care and resources are distributed among clients. The situation involves one client's personal choice, not the equitable sharing of treatment. So justice does not apply. B is wrong because fidelity means keeping promises and commitments to a client. Refusing a surgery is about the client's freedom to decide, not about a promise the nurse made, which makes fidelity the wrong fit. C is wrong because beneficence is acting to promote good for the client. Although surgery might help, forcing it would override the client's wishes. So respecting the refusal reflects autonomy rather than beneficence. Autonomy is the ethical principle that a competent adult has the right to make decisions about their own body and care, including the right to refuse treatment. The word comes from Greek roots meaning self and rule, literally self-governance. This principle answers a long history of medicine, treating patients as subjects to be managed rather than partners to be consulted. It rests on respect for persons, the idea that a competent adult is the rightful author of their own life, and overriding their choice treats them as a means rather than an end. In practice, honoring autonomy means giving the client the information needed to decide, making sure the choice is voluntary and free of coercion, and then respecting whatever decision follows, even if the nurse would choose differently. Consider a client with severe heart disease who refuses a recommended operation. The team believes surgery gives the best chance of survival, yet the nurse who upholds the client's competent, informed refusal is protecting autonomy, not abandoning good care. The line is competence and information, not agreement. As long as the client understands the risks and isn't impaired in judgment, the decision stands. When beneficence and autonomy collide, Respect for a competent choice wins, since overriding it in the name of doing good is paternalism, the very thing autonomy was built to prevent. Question 12. A nurse questions a medication prescription that appears too strong for a frail older client in unstable condition. Which ethical principle guides this action? Your options are A. Fidelity, B. Veracity, C. Non-maleficence, D. Justice. What's your answer? Commit to one before I continue. The correct answer is C. Non-maleficence. C is correct because non-maleficence is the commitment to do no harm. By questioning a prescription that could injure a vulnerable client, the nurse acts to prevent harm, which is the heart of this principle. A is wrong because fidelity is about fulfilling promises made to a client. Challenging an unsafe prescription protects the client from injury rather than keeping a commitment. So fidelity does not describe this action. B is wrong because veracity is the duty to tell the truth. The nurse is preventing potential harm, not deciding whether to be honest, which means veracity is not the principle at work in this situation. D is wrong because justice involves fair distribution of care and resources. This situation concerns protecting a single client from a harmful dose, not fairness among clients. So justice is not the guiding principle. Non-maleficence is the ethical duty to avoid causing harm, rooted in the ancient charge to first do no harm. It sets a flaw beneath all care. Whatever an intervention aims to accomplish, it must not needlessly injure the person receiving it. In practice, non-maleficence shows up as vigilance, checking that a dose is safe before giving it, questioning an order that looks dangerous, and stopping a plan whose risks outweigh its promise. A nurse who pauses over a medication that seems too strong for a fragile client is catching potential harm before it reaches them. Consider a nurse who sees a dose that appears too strong for a frail, unstable client. Rather than administer it, the nurse questions the order with the provider, guarding the client from an unsafe dose. That protective act, separate from any effort to actively improve the client, is non-maleficence in its clearest form. The signal words for non-maleficence are harm, injury, unsafe, too strong, risk, and prevent, while language about a positive step to improve comfort points to beneficence instead. Non-maleficence is the restraint that protects. Beneficence is an affirmative act that helps. The direction of the act, reaching toward help or away from harm, decides which principle applies. Non-maleficence is the refraining side of the ledger, the duty not to injure and to stop injury before it happens. Question 13. A nurse gives pain medication to a client before a painful dressing change so the client is more comfortable. Which ethical principle does this reflect? Your options are A. Beneficence, B. Autonomy, C. Justice, D. Fidelity. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Beneficence. A is correct because beneficence is action taken to promote good for a client without self-interest. Pre-medicating before a painful procedure to ease the client's discomfort is a direct example of doing good. B is wrong because autonomy is the client's right to make personal decisions. This action is about the nurse providing comfort, not about honoring a choice the client made. So autonomy does not apply here. C is wrong because justice addresses fairness in distributing care and resources among clients. Easing one client's pain before a procedure is a caring act, not a question of fair allocation across many clients. D is wrong because fidelity means following through on promises. The nurse's goal here is to relieve discomfort rather than to keep a specific commitment, which places this action under beneficence instead. Beneficence is the ethical duty to actively benefit the client, promoting well-being, comfort, and good, not merely avoiding harm. Simply refraining from harm accomplishes little. Beneficence answers what care is actually for, the affirmative obligation to make a client's situation better through comfort measures, pain relief, and advocacy. Picture a nurse preparing a client for a painful dressing change. Anticipating the discomfort, the nurse gives an analgesic beforehand, a deliberate, positive act chosen specifically to produce a benefit, not just to sidestep a harm. Signal words like benefit, promote, comfort, help, and relieve point to beneficence, while language about avoiding injury points to non-maleficence, and respecting choice points to autonomy. Non-maleficence is restraint from harm. Beneficence is action toward good. Autonomy is deference to the client's own decision. Giving pain medication to ease a procedure is a positive good. That's beneficence, distinct from the caution of non-maleficence and the deference of autonomy. Question 14. A nurse reviews several workplace situations to identify a true ethical dilemma. Which situation should the nurse recognize as an ethical dilemma? Your options are A. A coworker shows signs of impairment. B. Starting tube feedings for a dying client. C. Choosing a proxy for a client's decisions. D. Threatening to restrain a refusing client. Which would you go with? Lock it in before the reveal. The correct answer is B. Starting tube feedings for a dying client. B is correct because an ethical dilemma cannot be resolved by scientific data alone, pits two moral values against each other, and deeply affects the client. Deciding about feedings for a dying client meets all three. A is wrong because a co-worker who appears impaired is a legal and safety matter for the State Board of Nursing. Established law, not competing moral values, directs how the nurse must respond. C is wrong because selecting a proxy follows a defined legal process set by statute, because a clear legal pathway settles the question. No conflict of two moral imperatives exists to resolve. D is wrong because threatening to restrain a client meets the definition of assault. The law plainly labels this action wrong, removing any genuine ethical conflict and marking it a clear legal violation. An ethical dilemma is a situation where two or more moral principles pull in opposite directions. So honoring one means sacrificing another. It's not just a hard situation or an obvious wrong. It's a genuine clash where both sides have defensible arguments. When one course is plainly correct and the difficulty is only carrying it out, that's a problem, not a dilemma. A true dilemma exists only when principles of roughly equal weight conflict, letting a reasonable person argue either side in good conscience. Consider a client who is actively dying. One principle argues for tube feedings to sustain life, while another argues that forcing intervention only prolongs suffering and may override the client's wishes. Both positions rest on real ethical ground, which is exactly what makes this a true dilemma. The signal words that point to a dilemma are conflict, competing values, no clear right choice, and torn between. When any option sacrifices something ethically important, you're looking at a genuine dilemma rather than a simple violation or staffing frustration. A violation has a clear wrong and right, so the work is finding courage to act. A dilemma has no clear right, so the work is weighing principles against each other when both paths cost something worth protecting. Question 15. A nurse promises a client to return at the end of the shift to review discharge instructions and follows through. Which ethical principle does this show? Your options are A. Justice, B. Beneficence, C. Autonomy, D. Fidelity. Don't overthink it. Which one feels right? The correct answer is D. Fidelity. D is correct because fidelity is the fulfillment of promises made to a client. By returning as promised to review the instructions, the nurse keeps a commitment, which is exactly what fidelity describes. A is wrong because justice deals with fairness in distributing care and resources across clients. Keeping a personal promise to one client is unrelated to fair allocation, so justice does not capture this action. B is wrong because beneficence is acting to promote a client's good, although the visit helps. The defining feature here is honoring a promise, which makes fidelity the more precise principle for the situation. C is wrong because autonomy is the right of the client to make personal decisions. The nurse is keeping a commitment rather than supporting a client's choice. So autonomy does not describe what occurred. Fidelity is the ethical principle of faithfulness, the duty to keep promises and honor the commitments a nurse makes to a client. When a nurse says something will happen, fidelity is the obligation to make sure it does. Trust cannot survive broken promises. A client who is told a nurse will return or that a concern will be addressed builds real expectations on that word, and even small unkept promises erode the confidence a vulnerable person places in their caregivers. The nuance examiner's test is separating fidelity from the duties around it. Fidelity is specifically about keeping a commitment. It is not veracity, which is telling the truth, and not beneficence, which is doing good. The promise keeping itself, not any truth or benefit involved, is what identifies fidelity. Picture a nurse who tells a client she will come back at the end of the shift to review discharge instructions, and then does exactly that. The act of following through is fidelity. The nurse gave her word and honored it, reinforcing the client's trust that what nursing staff says will happen. Watch for words like promise, keep one's word, follow through, commitment, loyalty, and faithful. These point to fidelity. If a scenario is about telling the truth, think veracity. If it's about taking action to help, think beneficence. But a commitment made and kept is fidelity. Question 16. A nurse restrains a competent client and gives an injection that the client clearly refused. The nurse should identify this action as which of the following? Your options are A. Assault, B. Negligence, C. Battery, D. Defamation. Got a guess? Lock it in. The correct answer is C. Battery. C is correct because battery is intentional, unwanted physical contact with a client. Restraining the client and giving a refused injection involves actual touching against the client's will, meeting the definition of battery. A is wrong because assault is conduct that makes a client fearful of harm without any contact occurring. Here the nurse actually touched the client, which moves the situation beyond assault into a completed act. B is wrong because negligence is an unintentional failure to meet the standard of care. This injection was deliberate and against the client's refusal, so it does not fit an accidental lapse in care. D is wrong because defamation is harming a client's reputation through false statements. No reputation or spoken words are involved here, so this label does not match the physical act the nurse performed. Battery is an intentional tort defined as the intentional, non-consented touching of another person's body. It doesn't need to injure or be violent at the same time. It only needs to be intentional and unauthorized. The law protects bodily integrity because a competent person controls who may touch them and under what terms. Consent is what authorizes clinical contact. So care given without it becomes a legal wrong, regardless of good intentions. The key nuance examiner's test is the line between battery and assault. Battery requires that contact actually happen, while assault requires only the threat of contact with no touch necessary. Watch for signal words like touched, gave, injected, performed, and restrained or treated without consent, especially when a refusal is stated and then overridden. Real contact imposed without agreement always points to battery. Assault is the threat that creates fear. False imprisonment is unlawful confinement, but battery is the unauthorized contact itself. When a client is actually touched or treated without consent, the tort is battery. Question 17. Assistive personnel warn a client that they will be tied down if they keep climbing out of bed. The nurse identifies this as which of the following? Your options are assault, B, battery, C, negligence, D, false imprisonment. Which one is it? Pause the video if you need more time. The correct answer is A, assault. A is correct because assault is conduct that makes a client fearful and apprehensive, even without physical contact. A threat to tie the client down creates that fear by itself, which satisfies the definition of assault. B is wrong because battery requires actual unwanted physical contact, such as applying the restraints. Because the personnel only threatened and did not touch the client, the situation has not yet reached battery. C is wrong because negligence is a careless failure to meet the standard of care. This was a deliberate threat rather than an unintentional oversight. So it does not fit the meaning of negligence. D is wrong because false imprisonment means actually confining a client against their will. No restraint was applied and the client remained free to move. So a threat alone does not amount to confinement. Assault is an intentional tort defined as a threat that creates reasonable apprehension of imminent harmful or offensive contact. No touch is required because the wrong is the fear itself. The law recognizes assault because people have a right not to be put in fear of unconsented contact. Being threatened with force is itself a harm, separate from any contact that might follow, and protecting against assault protects a person's sense of bodily security. The key boundary examiner's test is between assault and battery. Assault is the threat and the fear it creates with no contact at all, while battery is the contact itself. The moment actual touching occurs, the tort shifts from assault to battery. Consider assistive personnel telling a client they will be tied down if they keep climbing out of bed. No contact has occurred, yet the client has been pushed into genuine apprehension, and that threat alone is assault. Signal words that point to assault include threatened, warned, intimidated, and any conditional statement promising unwanted force unless the client complies. When a scenario describes fear of contact that hasn't happened yet, the tort is assault, distinguished from battery by the total absence of physical contact. Question 18. A nurse applies restraints to keep a competent client who wants to leave from exiting the facility. The nurse should identify this action as which of the following? Your options are A, assault, B, beneficence, C, negligence, D, false imprisonment. Take a second. Which answer would you pick? The correct answer is D, false imprisonment. D is correct because false imprisonment is confining or restraining a competent client against their will. Using restraints to stop the client from leaving unlawfully limits freedom, which is exactly what this tort describes. A is wrong because assault is creating fear of harm without contact. The nurse did more than threaten, physically restraining the client, so the act goes past assault into unlawful confinement of the client. B is wrong because beneficence is an ethical principle of doing good, not a tort. Restraining a competent client against their will causes harm and restricts freedom, which does not promote the client's good. C is wrong because negligence is an unintentional failure in care. Restraining the client to prevent departure was a deliberate act, so it does not match the accidental nature that negligence requires. False imprisonment is the unlawful restriction of a competent person's freedom of movement against their will. It happens when someone is confined by physical restraint, locked barriers, or a refusal to let them leave without legal justification. The law protects this because liberty, the freedom to move and to leave, is a fundamental right. A competent adult cannot be held simply because staff disagree with their choice to go. Unjustified confinement is treated as a wrong in itself. Picture a competent client deciding to leave and a nurse applying restraints to stop them from walking out. The client has the right to leave and no legal ground exists to hold them, yet they are physically prevented from going. That confinement without justification is false imprisonment. Restraining a client involves touching, which resembles battery, and may involve a threat, which resembles assault. But when the purpose is keeping a competent person from leaving, the essential wrong is confinement itself, the loss of freedom, not merely the contact or the fear. Watch for signal words like confined, restrained against their will, prevented from leaving, detained, and not allowed to go. When a competent client is held or kept from leaving without lawful grounds, the tort is false imprisonment, distinguished by its focus on confinement rather than contact or fear. Question 19. A nurse does not complete a full risk assessment on admission and the client later falls and fractures a hip. The nurse's omission is an example of which of the following? Your options are A. Assault, B. Negligence, C. Battery, D. Breach of confidentiality. Before I reveal it, which one do you think is right? The correct answer is B. Negligence. B is correct because negligence is the failure to provide the care a reasonably prudent nurse would give, skipping the required full risk assessment, which then leads to client harm, fits the definition of negligence. A is wrong because assault is conduct that makes a client fearful of harm. The problem here was a missed assessment, not a threat. So assault does not describe what went wrong in this case. C is wrong because battery is unwanted physical contact with a client. The nurse failed to act rather than touching the client improperly, which means battery is not the correct label for this omission. D is wrong because breach of confidentiality is the release of protected information to an unauthorized person. No private information was shared here, so this tort does not apply to a missed safety assessment. Negligence is the failure to act as a reasonably prudent nurse would act under similar circumstances, resulting in harm to a client. Unlike intentional torts, negligence involves no intent to injure. The harm comes from carelessness, from falling below the accepted standard of care. Negligence works by comparing what the nurse actually did against what a reasonably prudent nurse would have done in the same situation. An omission counts just as heavily as a wrong action. Skipping an assessment or ignoring a change in condition can both fall below that standard. Consider a nurse who does not complete a full risk assessment at admission, and the client later falls and fractures a hip. A reasonably prudent nurse would have assessed the risk and put precautions in place. That careless failure, causing harm, is negligence. The signal words that point to negligence are failed to, did not, omitted, and should have. Any comparison to what a reasonable or prudent nurse would have done. Language describing a deliberate, unconsented act points instead to an intentional tort. Negligence is unintentional and rooted in a departure from the standard of care, with no malice and no plan to harm. When that negligence is committed by a professional in practice, it's called malpractice, the specific term for professional negligence. Question 20. A client falls and breaks a wrist after a nurse failed to raise the bed rails. Which element needed to prove negligence does the broken wrist represent? Your options are A. Duty to provide care, B. Foreseeability of harm, C. Harm to the client, D. Breach of the standard. What's your answer? Commit to one before I continue. The correct answer is C. Harm to the client. C is correct because proving negligence requires that actual harm reach the client. The broken wrist is the real injury that resulted, satisfying the harm element that completes the case for the negligence. I is wrong because duty refers to the care a nurse is obligated to provide by the standard. It describes the responsibility that existed, not the injury the client ultimately suffered from the fall. B is wrong because foreseeability means the nurse should have known the lapse could endanger the client. It addresses predictable risk beforehand, not the concrete injury the broken wrist actually represents. D is wrong because breach is the failure to meet the standard, such as leaving the rails down. It names the wrongful act itself rather than the resulting damage the client experienced afterward. Proving negligence requires 4 elements and every single one must be present at once. Miss any one of them and negligence cannot be established. Duty means the nurse owed the client a professional obligation. Breach means the nurse failed to meet that standard. Causation means the breach and nothing else produced the injury. Damages means the client suffered actual real harm. The test exists to keep liability tied to genuine injury, not to mistakes that hurt no one. Clinicians make near misses constantly, but only a broken chain running unbroken from duty to actual harm can support a negligence claim. Consider a client who falls and breaks a wrist after a nurse failed to raise the bed rails. The lowered rail is the breach. The fall is the causation linking failure to outcome, and the broken wrist itself is the damages. Signal words like harm, injury, and fracture point to damages, while facts about what the nurse failed to do point to breach. Matching each fact to its element is exactly what the 4-part framework is built to test. Question 21. A client about to sign a surgical consent form tells the nurse they do not understand the risks the provider described. Which action should the nurse take? Your options are A. Notify the provider to clarify the risks. B. Witness the signature and proceed. C. Explain the surgical risk to the client. D. Cancel the scheduled surgery. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Notify the provider to clarify the risks. A is correct because the provider is responsible for explaining a procedure's risks. When the client does not understand, the nurse notifies the provider to clarify before witnessing the signature, ensuring the consent is truly informed. B is wrong because witnessing the signature while the client remains confused defeats the purpose of informed consent. A signature gathered without understanding does not reflect an informed decision, so proceeding would be improper. C is wrong because providing the detailed explanation of surgical risks belongs to the provider, not the nurse. Stepping into that role would exceed the nurse's responsibility and could give the client inaccurate information. D is wrong because cancelling the surgery is outside the nurse's authority and skips the needed step. The correct response is to involve the provider so the client's questions are answered before any decision is made. Informed consent means a client voluntarily agrees to a procedure only after truly understanding it. That understanding must cover the diagnosis, the procedure itself, its risks and benefits, the alternatives, and what happens if nothing is done at all. This process exists to protect the client's autonomy and bodily integrity, because a person can't meaningfully agree to something they don't understand. The law places the duty of disclosure on the provider performing the procedure, since that provider knows the risks and alternatives best. The roles are divided on purpose. The provider explains the procedure and obtains consent, while the nurse witnesses the signature, confirms the client appears to understand, and acts as the client's advocate. Picture a client holding the consent form who tells the nurse the risks were never made clear. The nurse cannot let them sign, and cannot step in to explain the risks personally. That duty belongs to the provider, so the nurse must stop and call the provider back to clarify. When a client is unclear about the risk before signing, the safe action is never to proceed and never to explain it yourself, but to bring back the provider who is responsible for disclosure. Question 22. A nurse prepares consent documents for several clients. Which client is able to give independent informed consent for their own care? Your options are A. A confused older adult client, B. A school-aged child needing surgery, C. A sedated client before a procedure, D. A married minor living independently. Which would you go with? Lock it in before the reveal. The correct answer is D. A married minor living independently. D is correct because an emancipated minor, such as a married minor living independently, may consent for their own care. Independence from parents grants the legal standing to provide informed consent without a guardian. A is wrong because a confused older adult may lack the capacity to understand the information required for consent. When understanding is impaired, another authorized person must provide consent on the client's behalf. B is wrong because a school-aged child has not reached legal age and is not emancipated. A parent or guardian must give consent for the child, so the child cannot provide it independently in this situation. C is wrong because a sedated client cannot fully understand information or communicate a voluntary decision. Consent must be obtained before sedation, which means this client cannot give valid consent at this moment. Informed consent requires two things: legal authority and mental capacity. Without both, a consent isn't valid, no matter how willing the person seems. The default rule is simple: a competent adult consents for themselves, but a minor cannot, because the law presumes minors lack the maturity to weigh medical decisions. In that case, a parent or legal guardian consents instead. But the law makes an exception for minors who've already taken on adult responsibilities. An emancipated minor is someone below the legal age of adulthood who has nonetheless been granted adult legal standing. This status commonly arises through marriage, active military service, a court declaration, or living independently while financially self-supporting. Once emancipated, the minor can give independent informed consent just like an adult. Exam questions test whether you can spot the difference among an ordinary minor, an incapacitated adult, and an emancipated minor. An ordinary minor needs a parent or guardian. An incapacitated adult needs a surrogate decision maker, but an emancipated minor consents independently, exactly as an adult would. Watch for signal words like emancipated, married, active military, self-supporting, or court-declared adult. When a scenario names one of these, that client holds the authority to consent alone. Question 23. A client is admitted to the unit and reports having a living will. Which action is most appropriate for the nurse to take? Your options are A. Advise the client to cancel it. B. Keep the information from the team. C. Document it and inform the care team. D. Decide care based on the family's wishes. Don't overthink it. Which one feels right? The correct answer is C. Document it and inform the care team. C is correct because the nurse documents the client's advanced directive status and ensures the whole care team knows about it. Communicating the living will allow the team to honor the client's stated wishes. A is wrong because advising the client to cancel a living will override their right to direct end-of-life care. The nurse supports advanced directives rather than discouraging them, so this action is inappropriate. B is wrong because withholding the directive from the team prevents staff from following the client's wishes. The information must be shared so every member can provide care consistent with the living will. D is wrong because basing care on family wishes ignores the client's own documented choices. The living will reflects the client's decisions, which take priority over what family members might prefer for the client. A living will is an advance directive, thus a written record of a person's own wishes about life-sustaining treatment, made while they're still able to speak, for a time when they may not be. These documents exist because critical decisions often arrive after a person can no longer take part in them. The Patient Self-Determination Act of 1990 requires healthcare facilities to ask about advance directives and to honor what they say. When a client reports having a living will, the nurse's job is procedural: document that it exists, obtain a copy for the record when possible, and inform the provider and care team so the wishes are visible to everyone involved. Don't confuse the three. A living will states the client's own treatment wishes directly. A durable power of attorney names another person to decide. A do not resuscitate order is a provider's order to withhold CPR. The nurse never evaluates or overrides the document. The duty is simply to get it into the record and get the team informed, because a directive no one knows about cannot guide care. Question 24. A client without a do not resuscitate order is found with no pulse and no breathing. Which action should the nurse take first? Your options are: A. Wait for the provider to arrive. B. Begin cardiopulmonary resuscitation. C. Call the family for direction. D. Locate the client's living will. Got a guess? Lock it in. The correct answer is B. Begin cardiopulmonary resuscitation. B is correct because without a do not resuscitate order, the nurse must start cardiopulmonary resuscitation when a client has no pulse or breathing. Acting immediately gives the client the best chance of survival. A is wrong because waiting for the provider delays life-saving care during an arrest. With no order to withhold resuscitation, the nurse must act at once rather than pause for someone else to arrive. C is wrong because calling the family wastes critical time while the client has no pulse. Family input does not override the duty to resuscitate when no valid order to withhold care exists. D is wrong because searching for the living will postpone the response a pulseless client urgently needs. Resuscitation must begin first, since no documented order currently directs the nurse to withhold it. A do not resuscitate order is a provider's written instruction that CPR should not be attempted if a client's heart or breathing stops. Without that specific written order in place, the default for every client is full resuscitation. The system defaults to preserving life because withholding CPR from someone who wanted it can never be reversed. Only a valid written provider-entered order can authorize the team to stand back. Only a written provider order counts as a true do not resuscitate order. A spoken preference, a family member's opinion, and even a living will or advance directive expressing general wishes do not substitute for it. In practice, the order's presence or absence is the switch. If a valid DNR order exists, the team withholds CPR. If there is no order, the client is a full code, and the team begins CPR the instant they're found pulseless and not breathing. Remember the signal words: no DNR order, full code, found pulseless, not breathing. Without a written order in place, hesitation isn't an option, and resuscitation begins right away. Question 25. A nurse suspects that an older client is being abused by a caregiver at home. Which action is the nurse legally required to take? Your options are: A. Report the suspicion as required by law. B. Wait until the abuse is confirmed. C. Confront the caregiver privately. D. Keep the concern within the nursing team. Which one is it? Pause the video if you need more time. The correct answer is A. Report the suspicion as required by law. A is correct because nurses are legally obligated to report any suspicion of abuse following facility policy and state law. The nurse does not need proof, only a reasonable suspicion to make the required report. B is wrong because waiting for confirmation delays protection the client may urgently need. The law requires reporting based on suspicion alone, so holding back until abuse is proven violates that duty. C is wrong because confronting the caregiver is not the nurse's role and could place the client at greater risk. The proper step is to notify the appropriate authorities through the required reporting channel. D is wrong because keeping the concern within the team fails to meet the legal reporting requirement. Suspected abuse must be reported to the designated authority, not simply discussed among co-workers on the unit. Mandatory reporting laws require nurses to report reasonable suspicion of abuse or neglect involving children, older adults, and dependent adults. The duty is triggered by suspicion, not proof, because those most at risk are often the least able to speak up for themselves. The nurse's job stops at noticing and reporting. She does not need to confirm the abuse, gather evidence, or confront the caregiver. The designated authority, such as Adult Protective Services, takes over the job of investigating and intervening. This is where confidentiality gives way. A nurse cannot stay silent to protect a family's privacy or avoid a difficult accusation, because the protective purpose of the law overrides the usual duty to keep information private. Watch for phrases like suspect's abuse, mandated reporter, required by law, and a vulnerable or older adult in the care of another. When these appear, the correct action is always to report, never to investigate personally or stay quiet. Failing to report a reasonable suspicion can itself carry legal consequences. So when in doubt, the report comes first. Question 26. A nurse documents a client's behavior in the medical record. Which entry is written in the most factual, objective way? Your options are: A. The client is being very difficult today. B. The client seems very anxious. C. The client has a bad attitude. D. The client is pacing and speaking loudly. Take a second. Which answer would you pick? The correct answer is D. The client is pacing and speaking loudly. D is correct because factual documentation records what the nurse observes without judgment. Describing the client pacing and speaking loudly reports objective behavior, which is more accurate than labeling the client's mood or character. A is wrong because calling the client difficult states an opinion rather than an observation. Such judgmental wording does not describe measurable behavior and has no place in an objective, legal medical record. B is wrong because writing that the client seems anxious interprets a feeling instead of recording evidence. Objective charting describes the specific behaviors observed rather than the nurse's assumption about the client's emotion. C is wrong because describing a bad attitude is a personal judgment, not a fact. The record should capture observable actions, so this label fails the standard for accurate, descriptive documentation of behavior. Objective documentation records only what a nurse can directly observe or measure, stated as fact and free of interpretation. It captures behaviors, findings, vital signs, and the client's own words, without labeling or judging what they mean. This standard exists because the medical record is a legal document other clinicians rely on. A label like combative tells the reader nothing verifiable, while a description of the actual behavior lets them assess the situation directly. Examiners test whether you can catch words that sound factual but are really conclusions. Angry, difficult, confused, and non-compliant are judgments the writer has drawn, not things actually seen. Picture the same client charted two ways. One entry notes pacing, speaking loudly, and declining medication, while the other simply calls the client hostile or uncooperative. Only the first describes behavior anyone present could confirm. Signal words like observed, measured, described, and stated, plus quoted client speech, point to objective documentation. Remember, subjective data, the client report still belongs in the chart when quoted accurately. What's excluded is the nurse's own interpretation. Question 27. A nurse receives a telephone prescription from a provider during an emergency. Which action should the nurse take to handle it safely? Your options are A. Enter it from memory after the call. B. Wait to document it until later. C. Read the prescription back to the provider. D. Ask the family to verify the order. Before I reveal it, which one do you think is right? The correct answer is C. Read the prescription back to the provider. C is correct because reading the prescription back to the provider confirms the medication name, dose, route, and time are correct. This write-back step catches errors before the order is carried out, protecting the client. A is wrong because entering an order from memory risks mistakes in the drug, dose, or route. Safe practice requires writing it down and confirming it during the call rather than relying on recall afterward. B is wrong because delaying documentation leaves the order unrecorded and open to error. A telephone prescription should be written and verified immediately so the record stays accurate and the client receives correct care. D is wrong because asking the family to verify a prescription is inappropriate, since relatives are not qualified to confirm medical orders. Verification must occur between the nurse and the provider who gave it. When a provider gives a nurse instructions by voice instead of in writing, that verbal order carries extra risk, and a required safeguard exists to catch mistakes before they reach the patient. Spoken orders are a well-documented source of error, sound alike drug names, ambiguous doses, and simple mishearing can turn a correct intention into a dangerous mistake. Readback exists to catch these errors at the moment they happen. The nurse records the complete order, including drug, dossier, or route, and frequency, then reads the written version back word for word. Only after the provider confirms does the nurse carry it out with a signature to follow later. Picture the verification loop. The nurse writes, reads back, and the provider confirms, closing the gap between what was heard and what was meant before any medication is given. Writing the order down is necessary but not enough. The safe action is always to read it back and get confirmation, because that step is what turns a risky verbal exchange into a checked, accurate order. Question 28. A nurse makes an error while writing in a client's paper record. Which action follows correct documentation guidelines? Your options are A. Draw a single line through the error. B. Use correction fluid over the whole entry. C. Erase the mistake completely. D. Leave a blank space and continue. What's your answer? Commit to one before I continue. The correct answer is A. Draw a single line through the error. A is correct because correct practice is to mark an error with a single line so the original entry stays readable, then follow the facility procedure. This keeps the record honest and legally sound. B is wrong because using correction fluid hides the original entry and raises questions about what was changed. Legal documentation must remain visible and unaltered, so covering an error this way is prohibited. C is wrong because erasing a mistake removes information from a legal record and suggests tampering. The original words must stay legible, which is why erasing is never an acceptable way to correct a chart. D is wrong because leaving a blank space allows someone to add an entry later, which threatens the record's integrity. Nurses avoid blank spaces so the documentation cannot be altered after the fact. When a nurse makes an error in a paper medical record, there is one standardized way to fix it, and it isn't about making the mistake disappear. The nurse draws a single line through the incorrect entry, keeping it readable, then writes the correction nearby and adds the date, the time, and their initials. Nothing is hidden. The record shows both the mistake and the fix. This method exists because the medical record is legal evidence, and its value depends entirely on transparency. Anything that obscures the original entry looks like tampering, even when the intent was completely innocent. Picture the corrected entry itself, the original word still legible under one clean line, with the correction, date, time, and initial sitting openly beside it. That combination is what makes the fix accountable rather than suspicious. Erasing, blacking out, or using correction fluid all make an honest mistake look like falsification. The single line, dated and initialed, is what keeps a correction legally sound. Question 29. A nurse is giving a change of shift report to the oncoming nurse. Which information is most appropriate to include? Your options are A. Personal opinions about the client. B. Recent changes in the client's condition. C. Gossip shared by another staff member. D. Criticism of the previous shift. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Recent changes in the client's condition. B is correct because an effective shift report relays significant objective information and recent changes in medications, treatments, and condition. Sharing the client's recent changes gives the oncoming nurse what they need to continue care. A is wrong because personal opinions do not belong in a professional handoff and can bias the next nurse. The report should stay factual, focusing on the client's status rather than the nurse's impressions. C is wrong because gossip is unrelated to client care and undermines a professional report. Passing along rumors wastes time and adds nothing the oncoming nurse can use to care for the client. D is wrong because criticizing the previous shift turns the report into conflict instead of communication. The handoff exists to transfer accurate clinical information, not to judge how earlier staff performed their work. A change of shift report is the handoff where one nurse passes essential information to the next, so patient care continues without a gap. It's a focused summary, not a rereading of the entire chart. The handoff exists because continuity breaks down a shift change, and that break is a real danger point. If critical information lives only in one nurse's head, it disappears the moment that nurse leaves, unless a structured report moves it forward. An effective report centers on what is current and changing, the client's present status, recent changes, active problems, pending tasks, and priorities for the coming shift. Stable, unchanged history and things the oncoming nurse can read for themselves are left out. The essential content of a handoff is often confused with the exhaustive content of the chart. The chart holds everything, available to read anytime, while the report is selective and spoken, aimed squarely at safe continuity in those transition minutes. When a scenario asks what belongs in a change of shift report, recent changes in the client's condition are what the next nurse most needs to hear, not the complete history or routine unchanged findings. Question 30. A client falls in the hallway and the nurse completes an incident report. Which action is correct regarding that report? Your options are A. File a copy inside the client's record. B. Record personal opinions about the cause. C. Note in the chart that a report was filed. D. Keep the report out of the medical record. Which would you go with? Lock it in before the reveal. The correct answer is D. Keep the report out of the medical record. D is correct because an incident report supports quality improvement and stays separate from the medical record. The nurse documents the facts of the fall in the chart but does not mention the report itself. A is wrong because placing the report in the client's record merges an internal quality document with the legal chart. The two are kept separate, so filing it inside the record is incorrect handling. B is wrong because recording opinions about why the fall happened introduces judgment into a factual document. An incident report should state only what occurred, without speculation about cause or assigning blame. C is wrong because writing in the chart that a report was filed creates a link the facility intends to avoid. The medical record should describe the event itself, not reference the separate incident report. An incident report, also called an occurrence report, documents an unexpected event like a fall or medication error for the facility's own risk management review. It is an administrative tool and it never becomes part of the client's medical record. The report is kept confidential and apart from the chart precisely so it can serve internal review without becoming legal record. Even noting in the chart that a report exists would undermine that protection. Picture the same event splitting into two separate lanes. The medical record holds the objective clinical facts, the assessment, the notification, the care given, while the incident report travels on its own to risk management, and the two never cross. A nurse charts the clinical reality. The client was found on the floor, vital signs were taken, and the provider was notified. But the nurse never writes that an incident report was completed and never places it in the chart. Whenever a scenario describes completing an incident report, the correct action is always to keep it out of the medical record, submitted only to risk management. Question 31. A caller asks the nurse for details about a client's condition over the phone. Which action best protects the client's confidentiality? Your options are A. Share the details since they asked politely. B. Read the chart notes to the caller. C. Verify the caller's identity using the code. D. Transfer the call to the client's roommate. Don't overthink it. Which one feels right? The correct answer is C. Verify the caller's identity using the code. C is correct because facilities use an identity code, so information reaches only people the client approved. Verifying the caller's identity before sharing anything protects confidentiality and prevents disclosure to an unauthorized person. A is wrong because sharing details because a caller is polite ignores the duty to confirm who they are. Courtesy is not authorization, and disclosing without verification would breach the client's confidentiality. B is wrong because reading chart notes to an unverified caller hands protected information to a possible stranger. The contents of the record are exactly what privacy rules are designed to keep secure. D is wrong because routing the call to the roommate exposes the client's information to someone uninvolved in their care. That transfer spreads private details rather than safeguarding them as the privacy rule requires. Confidentiality means protecting a client's health information from anyone not authorized to receive it. Over the phone, that duty becomes harder because a voice alone proves nothing about who is really listening. The duty exists because health information is private, and its disclosure can harm a client's relationships, employment, and dignity. Federal privacy law reinforces what nursing ethics already demand. And since the telephone removes the visual cues that normally confirm identity, a deliberate verification step has to take their place. Facilities set up a verification method in advance, where a client designates a code word or personal identifier and specifies who may receive information. When a caller requests details, the nurse confirms identity using that prearranged code, and if the caller cannot be verified, information is withheld. The safe action is neither to release information freely nor to refuse all communication outright, but to verify first. Freely answering trusts an unverified voice. Refusing all contact is more restrictive than confidentiality requires. And confirming identity through the established code is the protective middle path. When a caller asks for client details over the phone, verify their identity with the agreed upon code before disclosing anything. That single step keeps the door open for people the client trusts and closed to everyone else. Question 32. A nurse finishes charting at a shared computer station and prepares to step away. Which action best maintains information security? Your options are A. Log off before leaving the workstation. B. Leave the record open for the next nurse. C. Share the password with a coworker. D. Write the password near the screen. Got a guess? Lock it in. The correct answer is A. Log off before leaving the workstation. A is correct because logging off before stepping away keeps unauthorized people from viewing or changing protected records under the nurse's access. This simple habit safeguards client information and the nurse's own credentials. B is wrong because leaving the record open lets anyone who passes by read protected health information. An unattended, logged-in screen exposes client data and violates the facility's information security expectations for staff. C is wrong because sharing a password lets another person act under the nurse's identity, erasing accountability. Credentials are personal and must never be given out, even to a trusted co-worker on the unit. D is wrong because writing the password near the screen makes it visible to anyone nearby and defeats access controls. Passwords must be kept private rather than posted where others can easily find them. An unattended logged-in computer is a doorway to every record reachable under that login. Closing that doorway before walking away is what actually keeps protected health information secure. Think of a signed-in session like leaving your front door wide open. Anyone who walks by can enter, look around, or even act in your name, and no one can prove it wasn't really you. The safeguard protects two things at once: confidentiality, so no unauthorized eyes see what's on the screen, and integrity, so no one else can chart under the nurse's name. Every entry must stay traceable to the person who truly made it, and credentials should never be shared. Minimizing the window, angling the monitor away, or simply trusting no one will look does not end the session. The risk lives in the open login itself, and only signing out removes it. When a scenario shows a nurse stepping away from a shared station, the secure action is always to log off first. That single act closes access and keeps the record's integrity intact. Question 33. A nursing student wants to post about an interesting clinical experience on a social media account. Which guidance should the nurse give? Your options are A. Posting is fine without using a last name. B. Sharing a room number is acceptable. C. Photos are allowed if the face is hidden. D. Avoid posting any client information or images. Which one is it? Pause the video if you need more time. The correct answer is D. Avoid posting any client information or images. D is correct because privacy rules prohibit posting client information or images on social media, even without obvious identifiers. The safest guidance is to share nothing about clients or clinical experiences that could expose them. A is wrong because omitting a last name does not make a post safe because other details can still identify the client. Privacy protection requires sharing no client information at all on social media. B is wrong because a room number can be linked to a specific client and reveals protected information. Posting it online breaches confidentiality just as a name would, so this advice would be wrong to give. C is wrong because hiding a face does not remove identifying features such as tattoos, settings, or surrounding context. Photographs of clients are prohibited on social media regardless of how the image is edited. Client health information stays protected no matter where it might be shared, and social media is no exception. The safe rule is simple and absolute: post nothing about clients, no information and no images on any personal platform. The rule exists because social media is public, fast, and effectively permanent. A post believed to be private can be copied, shared, and preserved far beyond its original audience, so once client information is online, the disclosure cannot be recalled. The nuance examiner's test is that removing the name is not enough. Details like the diagnosis, the date, the facility, the room, or the circumstances described can still combine to reveal exactly who the client is. Even a post that omits the name can still identify a client when a rare condition, a specific event, or a recognizable timeline points straight to that person. Whether it's a nursing student excited about a clinical story or any post about a client, the safest course is to keep the encounter off social media entirely. De-identifying is not enough. Posting nothing removes the risk completely. Question 34. A nurse is curious about the diagnosis of a client on another unit who is not under the nurse's care. Which action is appropriate? Your options are A. Open the record to satisfy the curiosity. B. Refrain from accessing the client's record. C. Ask a coworker to look it up. D. Share the question with the team. Take a second. Which answer would you pick? The correct answer is B. Refrain from accessing the client's record. B is correct because only team members directly responsible for a client's care may access that record. Because the nurse is not caring for this client, refraining from opening the record follows the privacy rule. A is wrong because opening a record out of curiosity is an unauthorized access and a privacy violation. Having login ability does not grant permission to view clients the nurse is not caring for. C is wrong because asking a coworker to look up the information still results in unauthorized access to protected data. Routing the request through someone else does not make the snooping acceptable. D is wrong because raising the question with the team spreads interest in private information the nurse has no right to view. The appropriate choice is to leave the unrelated client's record alone. Access to protected health information is limited to those involved in a client's care, and only to what they need to provide that care. This is the minimum necessary need-to-know principle. Electronic records log every access, and each look is a potential intrusion into a person's private information. Limiting access to those with a genuine care relationship keeps client information from becoming a matter of general interest and preserves trust in the system. A nurse is authorized to enter the records of clients under their care for the purpose of that care. Reaching into the record of a client the nurse is not caring for falls outside that authorization, and opening that chart is itself the violation, even if nothing is ever repeated to anyone. The signal words examiners use are not assigned, another unit, curiosity, not under the nurse's care, and need to know. When a scenario describes a nurse wanting to view a record they don't care for, the correct action is to refrain from accessing it. A breach does not require disclosure. Viewing a record without a care relationship is already the wrong. So when curiosity tempts a nurse toward an unassigned client's chart, the correct action is simply to refrain from opening it. Question 35. A nurse notices a printed list of client names and diagnoses left on a counter in a public area. Which action should the nurse take? Your options are A. Leave it for the next shift to use. B. Post it on the unit board for reference. C. Remove and secure the printed list. D. Read it aloud to confirm the names. Before I reveal it, which one do you think is right? The correct answer is C. Remove and secure the printed list. C is correct because printed protected information must be kept secure and out of public view. Removing the list and securing or shredding it prevents unauthorized people from seeing client names and diagnoses. A is wrong because leaving the list in a public area allows anyone passing by to read protected details. Convenience for the next shift does not justify exposing client information to unauthorized eyes. B is wrong because posting names and diagnoses on a board displays protected information to everyone who walks past. Public display of client data is specifically prohibited under the facility's privacy requirements. D is wrong because reading the names allowed broadcast protected information to anyone within earshot in the public space. The goal is to secure the document, not to announce its contents to others nearby. Protecting client information isn't just about screens and passwords. A printed list of client names and diagnoses is protected health information in physical form, and leaving it exposed in a public area is a breach waiting to happen. Physical documents are easy to overlook and just as easy to expose. A page left on a public counter can be read, photographed, or carried off by anyone passing by. So privacy rules require reasonable safeguards for every form of information, paper included. Securing paper information means taking control of the exposed document right away, placing it somewhere protected, and disposing of it properly by shredding when it is no longer needed. The nuance examiner's test is that the correct response is active, not passive. Walking past the list or assuming someone else will handle it lets the exposure continue, while removing and securing the document ends the breach immediately. Electronic and physical rules are not different standards. When protected information is found unattended in a public space, the correct action is always to take control of it and secure it immediately. Question 36. A nurse is delegating tasks during a busy shift. Which task is appropriate to assign to assistive personnel? Your options are A. Assisting a stable client with bathing. B. Teaching a client about new medications. C. Evaluating a client's response to treatment. D. Developing a client's care plan. What's your answer? Commit to one before I continue. The correct answer is A. Assisting a stable client with bathing. A is correct because bathing a stable client is a routine, low-risk activity of daily living that fits the training of assistive personnel. Delegating that frees the nurse for tasks that require licensure. B is wrong because teaching about new medications requires nursing knowledge and judgment to confirm understanding. This responsibility stays with a licensed nurse and cannot be handed to unlicensed assistive personnel. C is wrong because evaluating a client's response to treatment is part of the nursing process and demands clinical analysis. Assistive personnel are not prepared to make that judgment, so this task is not delegable. D is wrong because developing a care plan relies on assessment and clinical reasoning reserved for the registered nurse. It falls well outside the routine support tasks assistive personnel are trained to perform. Delegation means transferring the authority to perform a task to another team member, while the registered nurse keeps accountability for the outcome. It lets one nurse extend care across more clients by assigning appropriate work to assistive personnel. Think of it like handing off a baton in a relay. The task moves to someone else's hands, but the nurse never stops owning the client's overall care. Delegation exists because nurses can't do everything themselves, and much of the routine work doesn't require nursing judgment. Delegable tasks share a clear profile. They are routine, they follow a standardized procedure, their outcome is predictable, and the client is stable. Bathing, feeding, hygiene, and positioning fit that profile perfectly. What assistive personnel cannot take on are tasks requiring assessment, teaching, evaluation, or clinical judgment. Those responsibilities remain with the nurse, no matter how busy the shift becomes. The line isn't about effort, it's about judgment and stability. Routine care of a stable client can go to assistive personnel, assessment, teaching, evaluation, and unstable clients always stay with the nurse. Question 37. A nurse must delegate enteral feeding for a client who has a head injury. Which team member is the appropriate choice? Your options are A. The unit's assistive personnel. B. A family member at the bedside. C. A transport volunteer. D. A licensed practical nurse. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. A licensed practical nurse. D is correct because enteral feeding for a client with a head injury carries risk and requires monitoring, so it suits a licensed practical nurse. The skill exceeds what assistive personnel may safely perform. R is wrong because assistive personnel are not trained to manage enteral feedings or watch for complications in a head-injured client. Assigning this task to them would place the client's safety at risk. B is wrong because a family member is not a qualified team member for delivering a clinical feeding. Responsibility for this skill type belongs to licensed staff, not to relatives present at the bedside. C is wrong because a transport volunteer's role is moving clients, not performing skilled clinical procedures. Enteral feeding requires nursing preparation that a volunteer does not have, making this delegation unsafe for the client. Safe delegation depends on the right person, matching a task to the team member whose scope of practice and competency actually cover it. The team is layered by license. Assistive personnel handle basic, routine care. The licensed practical nurse handles many skilled tasks for stable clients. The registered nurse owns assessment, planning, teaching, and complex or unstable situations. Take enteral feeding, delivering nutrition through a tube into the stomach or intestine. It requires verifying placement, controlling the rate, and watching for complications. Skills within the licensed practical nurse's scope, but beyond assistive personnel's training. A head injury raises the stakes because of aspiration risk, but the feeding itself remains a skilled procedure the LPN is trained for, so it still exceeds assistive personnel's scope. Watch for signal words enteral or tube feeding, skilled procedure, medication, wound care, and stable but not routine. Assistive personnel, LPNs and RNs are not interchangeable. When a skilled task must be delegated, the right person is the one whose scope actually includes it. Question 38. A nurse delegates morning care to assistive personnel and wants to follow the right direction and communication step. Which instruction is most appropriate? Your options are A. Help the client with morning care sometime. B. Do whatever the client seems to need. C. Assist the client to shower before 9. D. Take care of the client this morning. Which would you go with? Lock it in before the reveal. The correct answer is C. Assist the client to shower before 9. C is correct because clear delegation specifies the task, the client, and the expected timing. Telling the personnel to assist the client with a shower before a set time gives the direction needed for safe completion. A is wrong because asking for help with morning care sometimes leaves the task and timing vague. Without specifics, the personnel cannot know exactly what to do, which weakens safe and reliable delegation. B is wrong because telling personnel to do whatever the client needs shifts judgment onto unlicensed staff. Delegation should define the task clearly rather than leaving the decision about care to the delegatee. D is wrong because instructing them to take care of the client this morning is too broad to follow. Effective communication names the exact task and time frame instead of offering only a general statement. Delegation isn't just handing off a task. It's communicating it precisely enough to be done correctly and reported back accurately. A clear instruction names the client, the task, any limits or time frame, and what the nurse wants reported back. Assistive personnel aren't mind readers, so a vague handoff like help with morning care leaves the specifics to guesswork. Telling an assistant to assist a particular client to shower before 9 gives a concrete task, a named client, and a defined deadline. A vaguer phrase like help with morning care defines none of that, leaving the work to chance. When a scenario asks which instruction is most appropriate, look for these signals: clear and specific language, a stated time frame, and instructions on what to report back. That precision is what separates proper delegation from simply assigning a chore, ensuring the care happens as intended and on schedule. Question 39. A nurse plans to have assistive personnel help a newly admitted client walk for the first time. Which approach reflects proper supervision? Your options are A. Delegate the walk before assessing the client. B. Assign the walk after completing the assessment. C. Skip the assessment to save time. D. Let the personnel decide when to walk. Don't overthink it. Which one feels right? The correct answer is B. Assign the walk after completing the assessment. B is correct because proper supervision means the nurse completes the admission assessment before delegating ambulation. Knowing the client's status first ensures the walk is safe and that assistive personnel act on sound information. A is wrong because delegating the walk before assessing the client risks ambulating someone whose stability is unknown. The assessment must come first, so the nurse can judge whether walking is safe to delegate. C is wrong because skipping the assessment removes the information needed to keep the client safe during the walk. Supervision requires evaluating the client before handing the task to unlicensed staff. D is wrong because letting personnel decide when to walk places a clinical judgment on staff who are not prepared for it. The nurse must determine readiness rather than leaving the timing to the delegatee. Supervision is not just watching a task happen. It is a condition of delegation that covers what the nurse does before, during, and after handing off that task. The nurse must assess whether delegation is appropriate, give clear direction and monitor performance, then evaluate the outcome and step in as needed. This begins before the task is ever assigned, because accountability for the client never leaves the nurse. Take a newly admitted client's first walk. Until the nurse has evaluated the client's stability, strength, and safety, no one can know whether ambulation is safe or who should assist. The assessment must come first, and the delegation follows from it. Watch for signal words like newly admitted, first time, assess first, monitor, and evaluate the outcome. When a task depends on a client's current status, the supervised approach always assesses before assigning. Supervision is broader than oversight during a task. It starts with the judgment to assess before delegating. When a task depends on the client's status, the assessment always comes before the delegation. Question 40. A nurse considers which client's vital signs can be delegated to assistive personnel. For which client is delegation of vital signs appropriate? Your options are A. A stable client recovering from routine surgery. B. A client who just received naloxone reversal. C. A client with sudden chest pain. D. A client whose blood pressure is dropping. Got a guess? Lock it in. The correct answer is A. A stable client recovering from routine surgery. A is correct because delegating vital signs is appropriate for a stable client whose condition is predictable. A client recovering routinely after surgery fits that circumstance, so assistive personnel can safely measure the readings. B is wrong because a client who just needed naloxone to reverse respiratory depression is unstable and may deteriorate quickly. Such close monitoring requires a nurse's judgment rather than delegation to assistive personnel. C is wrong because sudden chest pain signals a possibly unstable client whose readings could change fast. The nurse should assess this client directly instead of delegating vital signs during a developing problem. D is wrong because a falling blood pressure shows an unstable, changing condition that needs skilled interpretation. Delegating these vital signs would place a deteriorating client with someone unable to act on the findings. Delegation isn't just about the task itself, it depends on the right circumstance. That means weighing the client's condition and the setting before assigning any task. Delegation works because it assumes a predictable outcome. When a client's condition becomes unstable, that predictability disappears, and a routine task can suddenly demand the nurse's own judgment and interpretation. Take vital signs as an example. For a stable client with expected, unremarkable readings, an assistant can safely take and record them. But for an unstable client, those same readings carry clinical meaning that only the nurse can interpret. The signal words pointing to the right circumstance are stable, routine, predictable, and uncomplicated recovery. Language describing an unstable or acutely changing client signals that even a routine task must stay with the nurse. A delegable task is not always delegable. The client's stability decides. Delegating vital signs fits a stable post-operative client, but never an unstable one. Question 41. A nurse begins the shift with 4 clients to see. Which client should the nurse assess first? Your options are A client requesting pain medication, B, a client waiting for discharge papers, C, a client asking about the meal menu, D, a client with new difficulty breathing. Which one is it? Pause the video if you need more time. The correct answer is D, a client with new difficulty breathing. D is correct because difficulty breathing threatens oxygenation, a basic physiological need that comes before other concerns. Using the airway breathing circulation framework, the nurse evaluates this client first to address a possible emergency. A is wrong because a request for pain medication matters and deserves attention, but it does not outrank a breathing problem. Comfort needs follow once the nurse rules out a threat to oxygenation. B is wrong because waiting for discharge papers is an administrative task with no urgency. A client struggling to breathe takes clear priority over paperwork that can be completed a little later in the shift. C is wrong because a question about the meal menu is a low priority concern. It can easily wait while the nurse attends to a client whose breathing difficulty may signal a developing emergency. When a nurse must decide which client to see first, the airway, breathing, and circulation framework ranks the threats. It orders problems by how quickly they kill, not by how dramatic they look. Airway comes first, breathing second, circulation third. A blocked airway or failing breathing starves the brain of oxygen within minutes, causing damage that is swift and irreversible, while circulation problems and everything else allow more time. The body tolerates some failures far longer than others. A blocked airway or failing lungs cuts oxygen to the brain almost immediately, which is why these threats are ranked above everything else. The nuance tested is separating a new acute threat from findings that are chronic, stable, or expected. Difficulty breathing, shortness of breath, a new or sudden respiratory change, and any threat to the airway are the signal words that mean move first. Pain, anxiety, and even bleeding can look urgent, but the ABCs hold firm. When one client has a new breathing problem and the others are stable, the breathing problem is seen first, because nothing else kills as quickly. Question 42. A nurse is setting priorities for a client who has several needs. Which need should the nurse address first? Your options are A, the client's worry about finances, B, the client's request for a visitor, C, the client's need for adequate oxygen, D, the client's concern about self-image. Take a second, which answer would you pick? The correct answer is C, the client's need for adequate oxygen. C is correct because Maslow's hierarchy places physiological needs at the base, so they take priority. Ensuring the client has adequate oxygen comes before psychological or social concerns, which the nurse addresses afterward. A is wrong because worry about finances is a real concern, but sits higher on the hierarchy than physiological needs. The nurse meets basic physical requirements before turning to the client's financial stress. B is wrong because A, request for a visitor reflects a love and belonging need, which ranks above basic survival needs. The nurse satisfies physiological priorities first and arranges the social visit a bit later. D is wrong because concern about self-image relates to self-esteem, near the top of the hierarchy. Such needs are met after the client's physiological requirements are met, and the client is stable and secure. Maslow's hierarchy of needs ranks human needs from most basic to most aspirational, and nursing uses it to set priorities. Lower needs must be met before higher ones can matter, and that logic shapes how we decide what to treat first. At the base sit physiologic needs like oxygen, water, food, elimination, and temperature regulation. Above them rise safety, love and belonging, esteem, and finally self-actualization, each level resting on the one below it. Within the physiologic base itself, needs aren't equal. A person survives far longer without food or water than without air. So oxygen sits at the very top of urgency, even within the most basic level of the hierarchy. Fear, embarrassment, and the desire for information are real, but none outrank a physiologic need for oxygen. Safety concerns rank above emotional ones, yet still fall below the physiologic base. So oxygenation always comes before comfort, teaching, or emotional support. When a client has both a physiologic and a psychosocial need, address the physiologic one first, led by oxygen. Anxiety and the wish to be heard matter, but they wait until survival needs are secured. Question 43. A client reports new abdominal pain. Before taking any other step, which action should the nurse perform first? Your options are A. Collect data about the client's pain. B. Notify the provider right away. C. Reposition the client for comfort. D. Document the pain in the record. Before I reveal it, which one do you think is right? The correct answer is A. Collect data about the client's pain. A is correct because the nursing process begins with assessment, so the nurse first collects data about the new pain. Gathering details such as location and severity guides every nursing action that follows. B is wrong because notifying the provider before gathering information leaves the nurse unable to describe the problem. Assessment must come first so the report to the provider is complete and accurate for the client. C is wrong because repositioning the client is an intervention that should follow assessment, not precede it. Acting before collecting data risks responding to a problem the nurse does not yet fully understand. D is wrong because documenting the pain is important but happens after the nurse assesses it. Recording an incomplete picture before collecting the details would produce an inaccurate entry in the record. The nursing process follows a fixed order: assessment, diagnosis, planning, implementation, and evaluation. Every step depends on the accuracy of that very first step, gathering data. Acting without information is just guessing. A diagnosis built on incomplete data will be wrong. A plan built on a wrong diagnosis will misfire. And an intervention chosen too soon can harm rather than help. Take a client reporting new abdominal pain. Before giving medication or doing anything else, the nurse first collects data about its location, quality, severity, onset, timing, and what makes it better or worse. Watch for signal words like new symptom, reports, first and before any other step. Language about giving a medication, repositioning, or notifying the provider describes later steps, not what comes first. When a client reports something new, the first move is always to collect information, not to intervene. Assessment comes before action every time. Question 44. A nurse realizes a client avoids walking because of fear of missing a phone call, then arranges for staff to answer it. Which level of critical thinking is this? Your options are A. Basic critical thinking. B. Complex critical thinking. C. Commitment. D. Scientific reasoning. What's your answer? Commit to one before I continue. The correct answer is B. Complex critical thinking. B is correct because complex critical thinking appears when the nurse analyzes a situation and creates a flexible solution. Recognizing the real reason the client avoids walking and adjusting the plan reflects that analytical level. A is wrong because basic critical thinking follows rules concretely and trusts experts without deeper analysis. The nurse here looked past the obvious and tailored a solution, which goes beyond the basic level. C is wrong because commitment describes a nurse independently making and owning a decision without consultation. This situation centers on analyzing the client's behavior and adapting care, which fits the complex level instead. D is wrong because scientific reasoning is a general method of inquiry, not one of the named levels of critical thinking. Labeling the action this way misses the analytical, problem-solving nature of the nurse's response. Critical thinking and nursing grows through levels of sophistication, and knowing these levels explains why some clinical reasoning is more advanced than others. Nursing education describes a progression from basic to complex to commitment. Basic thinking is concrete and rule-bound with a single right answer. Complex thinking recognizes multiple possible solutions, and commitment means choosing a path and standing behind it. Complex critical thinking is marked by independent analysis and creativity. The nurse separates the surface problem from its real cause, generates alternatives, and tailors a solution to the individual rather than applying a generic rule. Consider a nurse who notices a client avoiding walking. Instead of simply enforcing a rule, she discovers the client fears missing a phone call and arranges for staff to answer it so the client will walk. That hidden cause discovery and tailored fix is complex critical thinking. Basic thinking follows a single rule. Commitment chooses and owns a decision. But complex critical thinking creatively solves an individualized problem by finding its true underlying cause. Question 45. A nurse checks whether a client met the goal of walking the length of the hall without dizziness. Which step of the nursing process is this? Your options are A. Assessment, B. Planning, C. Implementation, D. Evaluation. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Evaluation. D is correct because evaluation is the step where the nurse compares the client's response to the planned goal. Checking whether the client walks the hall without dizziness measures goal attainment, which defines evaluation. A is wrong because assessment is the initial collection of data about the client's status. Judging whether a goal was met happens after care is delivered, so this action belongs to a later step. B is wrong because planning is where the nurse sets goals and selects interventions beforehand. Determining whether the walking goal was achieved occurs at the end of the process, not during the planning step. C is wrong because implementation is the actual carrying out of interventions. Measuring the result against the goal comes afterward, which makes this evaluation rather than the implementation step of care. Evaluation is the final step of the nursing process. The moment the nurse judges whether the client actually achieved the outcome set during planning. It asks a direct question: did the intervention work and was the goal met? By comparing the client's actual result against the intended goal, evaluation reveals what happens next. End the plan because the goal was reached. Continue it because progress is underway, or revise it because the approach isn't working. This turns care into a self-correcting cycle. In practice, evaluation requires a clearly stated, measurable goal to judge against. If the goal was for the client to walk the length of the hall without dizziness, evaluation is the act of checking whether the client did exactly that. comparing performance against the predetermined outcome to reach a verdict. Evaluation is most often confused with assessment because both involve collecting data, but assessment opens the process by gathering baseline information to identify a problem, while evaluation closes it by measuring whether the goal was met. Signal words like met the goal, achieved the outcome, and was it effective all point to evaluation. When a nurse checks whether a client met a previously set goal, that comparison of actual result to intended outcome is evaluation, not assessment. Question 4x. A nurse admits an older adult to an unfamiliar hospital room. Which action is the priority to reduce the risk of injury? Your options are: A. Finish the full admission health history first. B. Review the meal schedule in detail. C. Orient the client to the call light. D. Introduce other staff to the client. Which would you go with? Lock it in before the reveal. The correct answer is C. Orient the client to the call light. C is correct because orienting an older adult to the room and call light first reduces the risk of injury in an unfamiliar setting. Safety needs take priority over completing paperwork or other admission steps. A is wrong because finishing the health history is part of admission, but does not address immediate safety. The client could be hurt in the unfamiliar room before the lengthy paperwork is ever finished. B is wrong because reviewing the meal schedule is helpful, but carries no urgency. Orienting the client to the environment protects against falls, which matters more than mealtime information at admission. D is wrong because introducing staff is courteous, yet does nothing to prevent injury in a new room. The priority is helping the client safely manage the environment, especially summoning help when needed. For a newly admitted client, especially an older adult, the first safety action is orienting them to the room and, above all, to the call light. A new admission combines an unfamiliar environment with the vulnerabilities of age. A client who doesn't know where the bathroom is or how to call for help is far more likely to try managing alone and fall. Orienting a new client means walking through the room, the bathroom, the bed controls, and especially the call light, confirming it's within reach and that the client knows how and when to use it. This is the nuance tested. Enabling the client to call for help is the first line of fall prevention, ahead of reactive measures like raised rails, bed alarms, or frequent rounding. Those support safety, but only the call light gives the client control before a fall happens. For a new admission, orienting the client to the call light is the foundation of injury prevention, letting them ask for help instead of facing a strange room alone. Question 47. A nurse is admitting a client to the medical unit. When should the nurse begin discharge planning for this client? Your options are: at the time of admission. B, on the day of discharge. C, after the client improves. D, once the provider writes the order. Don't overthink it. Which one feels right? The correct answer is A, at the time of admission. A is correct because discharge planning begins at admission, so the team can prepare for the client's needs at home from the start. Early planning supports a smooth, well-organized transition out of the facility. B is wrong because waiting until the day of discharge leaves no time to arrange equipment, services, or teaching. Effective planning must start much earlier so the client's home needs are ready in advance. C is wrong because delaying until the client improves assumes recovery is predictable and risks a rushed discharge. Planning from admission lets the team adjust as the client's condition changes over time. D is wrong because starting only when the provider writes the order overlooks the nurse's ongoing role in preparation. Discharge planning is a continuous process that begins well before the final order appears. Discharge planning is the process of preparing a client for a safe move out of the facility, and its defining principle is timing. It begins the moment a client is admitted, not the day they leave. Early planning exists because none of this happens instantly. Equipment must be ordered, home services set up, teaching completed, and referrals and follow-up scheduled. Starting at admission gives the team the runway to assemble everything, preventing last-minute delays and readmissions. In practice, this means assessing the client's home situation, support system, and needs right at admission, then building toward them throughout the stay. By the time discharge approaches, the groundwork is already laid, making the transition a smooth handoff rather than a scramble. The event is only the moment the client leaves, but the planning is a process running the entire length of the stay. Waiting until discharge is near leaves too little time to arrange services, and it's a frequent cause of unsafe transitions and readmissions. When a question asks when discharge planning should begin, the answer is the time of admission, not the day the client goes home. Question 48. A nurse is transferring a client to another unit and gives a verbal report. Which information is essential to include? Your options are A. The nurse's personal opinion of the family. B. Personal details unrelated to care. C. Complaints about staffing on the unit. D. The client's current status and recent changes. Got a guess? Lock it in. The correct answer is D. The client's current status and recent changes. D is correct because a transfer report must convey the client's current status, recent changes, and care needs so the receiving nurse can continue safely. This information maintains continuity of care during the move. A is wrong because the nurse's opinion of the family is subjective and not part of a clinical handoff. A transfer report focuses on the client's condition and care, not on personal impressions of relatives. B is wrong because personal details unrelated to care add nothing the receiving nurse needs. The report should carry clinically relevant information so care continues without gaps after the client transfers units. C is wrong because complaints about staffing belong in a different conversation, not in a client handoff. The transfer report exists to share the information required to keep caring for the client safely. When a client transfers between units, the handoff report has one job: give the receiving nurse an accurate, current picture so care never skips a beat. The essential content is the client's current status and recent changes, plus active problems, ongoing treatments, and immediate priorities. The receiving team is stepping in fresh, so they need to know where the client stands right now. A focused handoff often follows the SPA structure: situation, background, assessment, and recommendation. It leads with who the client is and why they're transferring, then centers on current status, active problems, and what to watch for next. The complete chart holds the full history and is always available to the receiving team. The verbal report is not a recitation of that chart, it's a focused snapshot of what's happening now. When a question asks what's essential in a transfer report, the answer is the client's current status and recent changes, since that's what keeps the handoff safe, focused, and free of unnecessary noise. Question 49. A competent adult client decides to leave the facility against medical advice. Which action should the nurse take? Your options are A. Physically prevent the client from leaving. B. Notify the provider and explain the risks. C. Tell the client they are not allowed to go. D. Ignore the decision and continue care. Which one is it? Pause the video if you need more time. The correct answer is B. Notify the provider and explain the risks. B is correct because a competent client has the right to leave. The nurse notifies the provider, explains the risks of leaving early, asks the client to sign the against medical advice form and documents the event. A is wrong because physically preventing a competent client from leaving is false imprisonment. Clients retain the right to refuse care and depart, so restraining the client here would be unlawful. C is wrong because telling the client they cannot go denies a competent adult's legal right to refuse care. The nurse should inform the client of the risk rather than forbidding the departure outright. D is wrong because ignoring the decision skips the nurse's duty to inform the client and document the situation. Proper steps protect both the client and the nurse, so doing nothing is inappropriate. When a competent adult wants to leave against medical advice, the nurse faces two duties in tension: respecting the right to go and protecting the client from an uninformed choice. A competent adult cannot be held against their will, so restraining them is unlawful confinement. But letting them walk out unaware of the danger fails the duty to inform, so the nurse must honor both at once. In practice, this means notifying the provider so they can speak with the client, explaining the specific risks in terms the client understands, and documenting the discussion, often with a signed form acknowledging those risks. Physically stopping a competent client is false imprisonment. Simply letting them walk out with no discussion neglects the duty to inform. The correct path threads between these two extremes. Watch for signal words like against medical advice, competent adult, and wants to leave. These point to one action: notify the provider and explain the risks, so the client's right to leave stays fully informed. Question 5. A nurse provides discharge instructions to a client going home with a new treatment. Which action best confirms the teaching was effective? Your options are: A. Ask if the client has any questions. B. Hand the client a printed sheet. C. Have the client explain the steps back. D. Tell the client to call if confused. Take a second. Which answer would you pick? The correct answer is C. Have the client explain the steps back. C is correct because asking the client to explain the steps back confirms understanding rather than assuming it. This teach-back approach lets the nurse catch and correct gaps before the client manages the treatment alone. A is wrong because asking whether the client has questions invites only a yes or no and may miss real gaps. A silent client could still misunderstand, so this does not truly confirm that learning occurred. B is wrong because handing over a printed sheet provides a reference but does not show the client understood it. Written material supports teaching, yet cannot verify that the client can perform the treatment. D is wrong because telling the client to call if confused shifts responsibility to the client after discharge. It does not check understanding now when the nurse can still clarify the instructions in person. Confirming that client teaching actually worked calls for more than a yes or no exchange. The most reliable method is teach-back, having the client explain the steps in their own words or demonstrate the skill. Asking a client if they understand almost always yields a yes, out of politeness, embarrassment, or a mistaken belief the material was clear. That yes proves nothing, because understanding is shown by what the client can reproduce, not by what they claim. In practice, the nurse asks the client to state the instructions in their own words or perform the task while observing. If the explanation reveals a gap, the nurse reteaches that part and checks again, continuing until the client can reliably reproduce the information. Handing over a pamphlet, asking if the client has questions, or asking if they understand does not confirm learning. Only having the client explain or demonstrate the material shows what was actually absorbed. When the goal is to confirm effective teaching, the client's own explanation or demonstration is the evidence that counts, not their assurance that all is clear. That brings today's Management of Care review to a close. If you're craving more practice, head over to our website where hundreds of free practice questions and complete study guides are waiting for you. Whatever subject you're tackling, there's plenty to sharpen your skills. Click the link in the description and keep building your knowledge and confidence one question at a time. Subscribe and stay tuned for the next part. Good luck on your exam.